How are you?
Doing good, sir. Nice to see you.
Yeah, nice to see you too.
Yeah, I thought you were somewhere doing cerebral palsy camp or something, Ashok.
Yes, sir. Yesterday.
Every day you are on the road.
Yeah. We went to Satara yesterday.
Okay,
2 days camp.
Okay. I think we should get going, Amit.
Yes,
Yeah, that's why I said we have already committed to this time. We should go.
Okay.
There are 12 participants anyway, so at the moment, counting us. So that's fine.
Okay, no problem. So thank you everyone for attending. I'd like to welcome Dr. Raja Reddy, who's a friend and a colleague. He's a consultant anaesthetist at Medway Hospital. He's also the president of the World Association of Pain, and he provides his expertise with pain management for both pre-op and post-op pain in patients. And he's here to talk us about non-operative management of degenerative joint disorder. I'd like to thank Professor Amit Tolat, who's the current president of BIOS, who's co-chairing this session, as well as OrthoTV Online for broadcasting this worldwide. For any questions, please put it in the chat box, and then we will try and answer as we go along, or if there's specific to Dr. Reddy, then we'll do it towards the end of the session. Thank you, Raja.
Right. Thank you, Amit and Bijay, and good morning to all the delegates on an early Sunday morning from here in UK. And I'll be talking about non-operative management of degenerative joint disorders. I had done a similar talk at the BIOS meeting where it was labeled radio frequency sensory denervation of the major joints. But I think we've tweaked this a little bit to get in more trainees as well as consultants. So as Bijay introduced, I'm Dr. Reddy. I'm a consultant anaesthetist and pain physician at Medway. I'm also a certified interventional pain sonologist and educational supervisor for pain management fellowship programs here. I wear other caps as well, as Bijay said, but let me talk you through these slides and this talk now. So the objectives of this presentation is mainly to understand the non-surgical options available for patients with knee and hip osteoarthritis. And for this, we need to understand the sensory innervation of the knee and the hip, especially the articular nerve supplying the anterior capsule of both of them, although I will talk a bit of the posterior capsule as well. And then to identify targets, both under ultrasound and fluoroscopy. And also we'll discuss available evidence and the outcomes from these evidence. And finally, the complications and adverse effect of all the options available for these joint disorders. A little bit about the epidemiology. Based on evidence and many articles, we still know that symptomatic knee OA is present in approximately 20 to 30% of all population aged more than 65 years. And also the lifetime risk of developing this is estimated approximately 45%. And given the increasing life expectancy and high BMI, I think the prevalence of knee OA is only going to increase in the coming future. So we need to be prepared. Now, I think blessed are those who have advanced severe symptomatic osteoarthritis because there is a definitive management plan, and that is arthroplasty, whether it's hip or a knees. And this was confirmed in the National Joint Registry, where we do approximately 100,000 of them. And then in the PROM study, where the patients are so happy with the hips and knee replacement. But again, approximately 15 to 20% of the patients can still have post-knee or post-hip pain in spite of normal biochemistry and normal imaging. So I think we have to look into that as well. Right. So for patients with non-surgical options, who are these patients? Arthroplasty is not an appropriate option, and what will be the circumstances? It could be mild to moderate OA, extremes of age. It's a very young patient with moderate osteoarthritis, or very elderly patient with too many comorbidities where it's not appropriate for surgical options. Very high BMI. Now each zone, even in around Southeast England, has got different BMIs, wherein the cutoff target might be 40. But a few orthopedic surgeons whom I know have said in their personal opinion that even with BMI of 45, their outcomes, their personal experience has been good. But I think that's a very limiting option, the high BMI. And the other thing is the lifespan of the implant. I mean, I know we got more than 10 or 15 years now, but then again, you need to plan it in such a way. And the revision surgery, wherein both the surgeon and the patient might be reluctant to have multiple revisions. So these are the indications wherein we need to explore non-arthroplasty options. So what's the other group? It's not acceptable to the patient. There are few patients who don't want to take the risks associated with arthroplasty, and therefore it's not available. It's not an option for them. And the third group of patient will be post-arthroplastic pain. Now, as I mentioned in my previous slide, approximately 20% will still have chronic pain in spite of normal biochemistry and normal imaging. There's no loosening of the implant. There is no signs of infection, but they'll still have hip and knee pain. And this is approximately, as I mentioned, 20%. And there are other reasons as well. One of the reasons is very simple to treat. If it is a localized neuromas, you can identify them and treat them. Second one will be implant failure, as I mentioned. Third one is infection. Finally is the central sensitization. It's not exactly CRPS, but the features are such that it's not infection, but very sensitive areas. Under those indications, we try not to intervene with the knee, but we try to target the dorsal root ganglion of L2 and L3 supplying the knee. I'll speak about that later. And so what is the mechanism for persistent pain following arthroplasty? I always ask the audience, or the audience asks me, what is the mechanism of pain relief following arthroplasty? Then I mentioned it could be surgical debulking, denervation. But then the audience asks, but sir, cartilage doesn't have any nerve supply. They are right. So it is a neural structure. So loss of joint space doesn't mean anything unless the subchondral bone is exposed. Probably that is why there could be some loss of joint space, but then they're asymptomatic without any pain, because I think the nociceptors are not exposed to the chemical irritation, etc. So I think in my next series of lecture, which Bijay and me have been planning, we'll be talking about nociception in osteoarthritis. Therefore, the nociceptive structures are usually the joint capsule, the synovium, and the subchondral bone, and it is never the cartilage. So that's one of the mechanisms we talk about persistent pain after surgical denervation. And also, after any surgical operation, the healing process involves neovascularization. New blood vessels are formed, and usually the nerves follow the blood vessels. As a result, the normal neural architecture is lost because of the new onset, the new blood vessels, and there are many more nerves around. That is why some of the
are listening in. But what I wanted to ask you was that, we have quite a lot of pain patterning with patients waiting for surgery. So do you think that addressing these problems prior to surgery by effective pain management could reduce some of the negative outcomes? Say, for example, a patient who has knee osteoarthritis for a long period of time waiting for surgery and then has an adverse outcome after the knee replacement because of persistent pain. Do you think that long-term pain that they had before, if it was addressed effectively, could reduce the adversity of outcome afterwards, subsequently? Hello? Raja, you're muted. You're muted, Raja.
Yeah.
Yeah,
Is it
now
clear
you're
now?
on. Yeah. Did you get my question?
Amit, I think you need to type a question. I can't hear you.
Oh, okay. All right.
Okay.
Can you
I've got
hear
a
me?
question
Let me open up my. I mean, the speaker volume is max. I shouldn't have any problem.
You said you could hear me before, so
Yeah, now I can hear you, Amit.
okay, all right. Let's make it brief. Do you think that giving effective pain management for people with long-standing, symptoms, say knee osteoarthritis, and then having the operation, so would it mean that their possibilities of having less pain after the surgery would be much better if you effectively manage this preoperatively? Because you see people with knee replacements who don't improve because they have some pain persistent after the surgery as well and never goes away. Did you get that question?
Yeah.
Okay.
Now, look, most of the patients we get are usually referred by the orthopedic surgeons in the first place. So, and I mentioned in my early slide, if there is any persistent pain after arthroplasty, it is seen by the orthopedic surgeons first. And I think they do all the inflammatory markers, x-rays, cell scan, and they want to rule out both implant failure and infection. And once that is ruled out, then they say, okay, then probably they would consider revision if they think for whatever reason. And then they say, okay, let me refer you to the pain clinic. So that is when we come in to do the needful for post-arthroplasty patients.
Okay, right. Basically, what I was saying was that if they had quite a lot of pain patterning prior to the operation, would effective non-operative management, whether it be radiofrequency, whatever other modalities, reduce that risk of that patient developing the CRPS after the surgery? Do you think that there's any scientific evidence connecting that? Raja, did you get that?
I didn't get it, Amit.
Oh, it's episodic. Okay, right. Let's. Bijay, do you want to do the Q&A?
Okay. So, Raja, there's a question. What will be the anticipated complications of radiofrequency? That's one. The second one is, do you get neuroma formation? And how do you manage it?
Can you hear me?
Yes.
Yes, look, insofar in the 5 years or 6 years I've been doing radiofrequency ablation of the knees and the hip joints, so far we have had zero complications. The trick is to do it both under ultrasound and fluoroscopy. Whatever reports have come is they've not used the dual approach, meaning you would have gone straight with your fluoroscopy only to target especially the hip joint. And that means you got no idea where your femoral nerve will be, or the patient would have been sedated. So that is why femoral neuropathy has been one of the highest incidence of the nerves being affected by this procedure. Therefore, one of the safety features is to identify your blood vessels, place the needle under ultrasound, and then do the target structure. That is one thing. And we also seen that in very high BMI patients, even reaching the target tissue under fluoroscopy can be very difficult. Very difficult. It's taken sometimes more than 1 hour to get into the target areas, both with ultrasound and fluoroscopy. The incidence based on the papers is almost 1% is the reported complications. And it's usually the blood vessels and the nerves of the femoral, and same thing with the knee. With the knee, because we don't do the posterior capsule, so that's very rare incidence of the blood vessels being, being injected or being targeted. But
I think he's got a Wi-Fi problem.
Looks like.
Because it's episodic interconnection and failure. So now he's gone completely frozen. Raja, you're completely frozen. Maybe he can rejoin.
He's coming on.
He's coming back on. Maybe he's just rejoin.
Any other questions, guys? Otherwise, we'll wrap up.
I think so. There's in the Q&A. There's only a thanks from one of the attendees, and
Nitesh. Mr. Gogi has joined, and Prof. Shetty is here. Good morning, Prof. Shetty.
Hi. No, I'm there.
Nitesh is there. Nitesh is there.
Yeah.
I think Raja has had some Wi-Fi failure, so it's possible he was having these episodic connection problems. So, but we could just join now. It was very comprehensive.
Exactly, quite complete talk.
And the message was very clear, I think, for everybody in the audience that radiofrequency ablation seems to be having the most promising evidential base to the various treatments that were discussed. But this is obviously a semi-invasive procedure, and there are some risks associated with it, particularly in the hip, as I could make out, compared to the knee, where the risks are a bit less. But the hip, perhaps people need to approach radiofrequency with some caution, because that one paper that I saw where they described the risk of quadriceps palsy and various other things happening just does suggest that you've got to take this very carefully because of the vast neurovascular bundle around that. There you are, Raja.
Yeah, I need
summarizing some of your talk. Can you hear me as well?
No, I can hear you now. Yeah.
So your Wi-Fi must be the one. Yeah. Okay. Fine. Let's wrap it up quickly now. So, Bijay,
I can answer all the questions now.
Okay. Fine. Do you want to answer this question of mine?
Okay. Go ahead.
The question that I wanted to ask you, there were two of them, but first of all, what's your view on buprenorphine patches, pain patches? Number one, and number two. Are there any studies wherein they combine radiofrequency with other modalities, say like intraarticular steroid, hyaluronate, because you're talking of some semi-invasive treatment with radiofrequency? I didn't see any study that's compared the combinations of the two. So say a patient had physical therapy, had intraarticular injection and radiofrequency together, and what was the outcome?
Okay. So in terms of buprenorphine patches, we use these patches for a selective group of patients in whom taking medication is a compliance issue, because these patches last for 7 days and it is waterproof. And remember, these are partial agonists. They're not completely new, like morphine or Roxinam or Oxycontin, etc. So we use buprenorphine patches for elderly patients. Number two, for patients who want to come off morphine, because you see, it is when we have difficulty in getting patients off morphine, then we use buprenorphine.
Okay.
But it is a good option because the addiction with patches is less, because it's a partial agonist compared to a normal morphine medication, what you give.
Yeah, and I would have thought the gastric side effects would be much less as well.
I would say so. No, but it has got a hepatic bypass metabolism as well.
Okay, right.
So keeping all this in mind, the other option is the newer drug called tapentadol. I talked about. Why tramadol is popular in opiate medication is it's got 3 mechanisms of action. So it's got a partial mu action, and also it's got SNRI, whereas it reuptake inhibitors of noradrenaline and serotonin. Therefore, if the patient has got some neuropathic pain along with the inflammatory pain, the tramadol seems to work better, or the tapentadol seems to work better compared to plain opiates like codeine and morphine. Therefore, it's got 2 components. It covers both neuropathic and nociceptive pain. So that is one in terms of buprenorphine patch. We are very reluctant to prescribe opiates for patients with arthritis because you have better options than morphine. Number 2, there's no studies clubbing together, because I tried to see if there's one paper which is come, Amit, where they've clubbed hyaluronic acid with PRP together.
Okay, right.
And that seems to show good evidence. Can you imagine? 2 different mechanisms of action. So I think that's one of the mixed treatments I have seen so far. And now the PRP group is very happy that when you club it with hyaluronic acid, the outcome is better.
Right. Okay.
So very few papers have come, because I think there's a big ethical issue in approving such combination treatments.
I see.
Unless they do a crossover for the other patients, you see. So it's a very complex evidence it'll become. So that is why.
Yeah. No, thank you very much. Thank you
problem.
for that. And an excellent talk today. Thank you.
No problem. Bijay, I can hear you now. Rest of the questions.
Yeah, there aren't any at the moment.
Bijay is on the in the chat.
Bijay, you're on mute.
Bijay, you're mute.
Sorry. So
Bijay, I can answer them directly rather than questions. If you can read it for me, I can answer them directly.
Yeah, so it was about post-op knee pain, which I think you covered in your talk anyway, that it's that it is used for knee pain post-op.
No, I'd like to add something about post-op knee pain, Bijay.
Yeah.
Now, one of the primary outcomes after post-operative knee pain is pain relief. Okay. Secondary outcome is how soon they mobilize, and is there any quadriceps failure and other issues. There's a tertiary outcome as well, that is prevention of chronic pain. Now, to prevent chronic pain, you need to block the primary afferents, the sympathetic chain, and the dorsal root ganglion. Therefore, when you do a central neural blocks, like an epidural or like a spinal, there is an inbuilt mechanism to prevent chronic pain. And if you're doing only GA and a femoral nerve block, or a GA and a sciatic nerve block for knee pain, there's every chance that you're not giving the patient an opportunity to prevent chronic pain. The evidence says, it doesn't matter whether you do GA or spinal, the outcome is the same. But they're not comparing the chronic pain in these patients, you see. Based on my clinical experience, I always tell them, do the initial block, whether it's a spinal, usually a spinal, and then top it up with what you want, rather than do a GA and a nerve block, wherein you might say you're saving time. Post-op, the patients really struggle, and also you get quadriceps failure if you have done the femoral block only. So for post-op knee pain, there is a new thing. We do a spinal, and there is a thing called as an IPAC, wherein the needle is placed between the popliteal blood vessels and the posterior capsule, and ultrasound guidance, and there we inject local anesthetic so that it blocks all the popliteal plexus, and all the genicular nerves are blocked. Srinivas Samsani wants to do that audit, and we are planning to do it next year. Of course, we'll involve some orthopedic surgeons as well. And that seems to be the current trend compared to the adductor canal block or the femoral block or the sciatic block. No good. The evidence is very poor for post-op knee pain.
Thank you, Raja. There's no more questions so far. So I think I would like, on behalf of the university, myself, as well as BIOS, a big thank you for giving up your Sunday morning to provide us with an excellent lecture. Thank you once again. Thank you, everyone.
Thank you, Vijay. Thank you,
Thanks,
Amit.
OrthoTV.
Thank you. Thank you, Raja, as well, on behalf of BIOS. Thank you. Bye-bye.
Thank you. Bye-bye.
Recording stopped.